thrilled to be presenting the speaker who is here today is Gil Welch. I'll tell you a little bit more about him, and especially at the end, because we'll be presenting him with the award, the 2023 Innovator in Diagnosis Award, after his talk today. So Gil is a general internist and researcher at Brigham and Women's Hospital in Boston. I think for this crowd, probably the most important bit of information is besides having done a lot of publishing and other things, he comes at questions from being a clinician on one hand, and then an epidemiologist who taught epi and biostats on the other hand. And I think having strong skill sets in both of those is just a very valuable approach to both understanding the numbers, but then saying in real life, who are those people, and how does that translate to the day-to-day. And I think that's something that's not, you're not required to have an MD to do that, but it takes a lot of work to figure out both of those skill sets. Like, what do the numbers tell you and what does real life tell you, kind of the qualitative part. So I'm going to let Gil start talking, and then we'll present the award at the end. And Gil will be presenting today bias measures in early detection.
Thank you, Dan. And thank you for coming. A quick disclaimer, this is a new talk. I didn't just put it together for you, but I've been meaning to kind of put it together. And it's a very elementary talk, and that's purposeful. I want to make sure everyone's with me and understands what I'm talking about, because I'm hoping you will help communicate these issues to medical students. I assume some of you teach medical students about epidemiology and numbers and so forth. I think we get way too fast and too complicated too early, long before we discuss the more basic measures and their problems. We're in a multivariate analyses and controlling for confounding. We got, negative binomials. I have no idea what that really is, but and we focus on the complexity, and we don't make things simple. And I'm going to try to make things very simple today. And I'm going to start with the title of my talk and the language, the biased measures in early detection. And I just want to start with the word biased, because that brings up, you can know that's a hot button word just from the start. So we really have to start when we talk to medical students about bias, what we mean by that. And what I mean by it is a systematic error as opposed to a random error, something. And I say, I think of random errors as being sort of the domain of biostatistics, and systematic areas being in the realm of epidemiology. It moves things in one direction. So I'm talking about things that only move things in one direction. And they're misleading or deceptive. They're telling you something, they apparently suggest something that may not be true, because they're moving in a fixed direction. Early detection, you may think, oh, you know exactly what that is, but it's actually kind of a number of factors at work in earlier detection of disease. You may associate this word with screening, and you're absolutely right. That is our purposeful effort to try to advance the time of diagnosis in asymptomatic patients. But it's not just screening. Increased diagnostic scrutiny in general will lead to more early detection. And what do I mean by increased diagnostic scrutiny? Well, I mean simply testing more people, testing people more often. Those are both forms of increased diagnostic. Or when our technology is applying more scrutiny. It can detect smaller abnormalities in the resolution of our imaging tests. So there's a number of things that come together in diagnostic scrutiny. A few more glossary of terms, just to make sure everyone's on the same page. This is the numerator and this is the denominator. Any questions? Okay. I know you know that, but I think, you may throw that word around. Really, it's really helpful. Okay, one other disclaimer. I started as a high school math teacher out of college. So I think you need to put yourself in the students' They've had calculus, and yet they may not immediately understand our interest in denominators. And a lot of our work is about, what's the right denominator? So again, very basic. So I'm only going to talk about two measures, and I'm going to talk about them in the context of cancer, but they're not just cancer. We have stages of cardiovascular disease. We have stages of congestive heart failure, so forth. We have stages of peripheral vascular disease. But my context will be cancer. But this applies well beyond cancer. And both those measures are biased, by which I mean they systematically move in one direction in the context of early detection. That's really important for students to know. These are both biased measures in one direction. Stage distribution is a proportion. The numerator is the number of late-stage cancers in its simplest form, and the denominator is the number of cancers diagnosed. So it is a fraction and a proportion. So let me give you an example. So this is the stage-specific incidence of breast cancer in American women age 40 plus from 1975 to 2015. And this is the incidence, stage-specific incidence of early stage breast cancer, local and ductal carcinoma in situ. So it pops up, as you see, in the decade of the 80s. That is, of course, associated with the implementation of widespread screening mammography in this country. What happened to late-stage disease? Well, not much. It stayed about the same. Now, this tells us something about the efficacy of mammography, but I'll come back to that later. But right now, I just want to focus on the question of the stage distribution. In 1975, you can see that the stage distribution was that about 50% of cases were late stage, because early and late are about the same. And I'm just rounding numbers, and I encourage you to round numbers with students. It makes it easier to understand the problem. And I'll round them again at the end. It moves to 25% late stage, and therein you see the problem. Right therein you see, like, wow, if you didn't have this graph, you would presume that there was less late stage disease. But there's not less late stage disease. There's more early stage disease, but the proportion doesn't tell you that. Right? Late stage incidence is the number of late stage cancers over the number of cancers diagnosed. More early stage inflates the denominator. Now, the one thing you should be clear about is when we hear differences in proportion, we always tend to assume it's something about the numerator. So we're assuming that that numerator was going down. There are fewer late stage cases, but in fact, what's happening is very different. The denominator is being inflated. Right? And I think it's very important that people say, changes in proportions may reflect the changes in the denominator. So this is the picture. The solution is not to talk about stage distribution. You want, as you would say, the absolute rates to know what the stage-specific incidence is doing, because the stage distribution, the so-called stage shift that everyone's looking for with screening, is misleading. What you want to know is there less late stage presenting? No, not in this case. Relatively flat. So the unbiased measure is stage-specific incidence, number of late-stage cancers over the population. I know you know that. Okay, let me give you a sense of how badly we can run off the rails here. This is an article from STAT. Pandemic slowed cancers diagnoses, but with late-stage cancers came back with a vengeance. Now, this is a very interesting article, and I went to the original article, and nicely, they had a figure with counts, which is pretty nice because the population's pretty stable. So we get this, and I'll give you some guidance because there's a lot here. Early stage is that top blue line. That is early stage. These are all cancers combined. All right, so that's early stage cancer. And the late stages are down there. And it doesn't really matter which is which. It happens to be 4 is at the top, but 3, 4, 2, 3, 4 down there. And the very bottom line is unknown stage. And as you can see, it doesn't change much, isn't the story. So here is the COVID-19 pandemic. And you can see first that all cancer diagnoses went down, right? Everyone can see that as a pandemic starts. And of course, that's because we're not testing people as much. But in fact, what stage goes down the most? Early stage goes down the most, yeah. Now, this is late stage cancer coming back with a vengeance? I don't think so, right? I mean, when you see the absolute numbers, you say, well, that's a crazy. That's not late stage coming back. This is late stage coming back, you know, coming back to baseline. And actually, you look at it and you say, oh, it's interesting. What stage was least affected by the pandemic? It's that, oh, it doesn't work on this surface. It's what color am I going to call that? A light orange? That light orange is stage 4. Right? It's the one that moves the least. Does that make clinical sense? Oh, yeah, it makes perfect clinical sense. These are people with metastatic disease who are presenting clinically, and they're least affected by the pandemic. So the stage distribution from here to here went from 20% being stage 4, late stage disease, to 30%. Well, why did it do that? Because early stage disappeared. Why? Because we weren't screening. We weren't finding early stage disease. But the stage distribution is totally misleading. It makes you think, oh, there's more people with, you know, metastatic disease. No, there are no more people with metastatic disease. There's just a lot less people with early stage disease. That's a really misleading metric. It's tempting to think what's happening is the numerator is getting bigger, that there's more late stage cancer out there. But in fact, what was happening was the denominator was getting smaller. It's a biased metric. All right, so don't use the stage distribution. If they had just shown this picture and didn't do anything else, it'd be pretty clear what had happened. First, very little. Second, there was less early stage diagnosis, and there's no surprise about that. First few months, we weren't doing a whole bunch of screening. Appropriately so during a pandemic. Okay, it gets worse. Dan, I'm going to pick on you because you invited me, you drugged me all the way here. I want you to read that. It is from the abstract, so it's not buried in the table.
The decrease of diagnosis was largest for stage 1 disease, leading to lower odds of being diagnosed with stage 1 disease in 2020 than in 2019. Adjusted odds ratio was 0.946 for stage 1 versus stage 2 to 4. Whereas the odds of being diagnosed with stage 4 disease were higher in 2020 than in 2019, 1.074 for stage 4 versus stage 1 to 3.
You got it? You read it? Do you understand it yet? No. I think the answer is no, right? I mean, okay, so that's the first thing, is like that is an impenetrable. Was it painful to read?
Yeah.
Yeah, and did you avoid reading the confidence intervals because you were tired?
Oh, yeah.
Yeah, okay, yeah. I mean, it's like, of course he did. Yeah, and do you need, and the 3 digits precision, is that overwhelming? Oh my God, like it's this false pseudo precision is like, are you kidding me? These all round to 1. I mean, that's the first thing. Like, I can't get excited about anything here when I round it, right? It's all rounds to 1. But let's just look at this, and boy, this is just crazy, Bill. Let's just start with the first sentence and break it down. So really what that odds ratio is, and odds ratios are odd, you all know that. Odds ratios are odd. There's occurrence to non-occurrence. It's not the way we usually think. And what we have is the odds of being stage 1 in 2020 in the numerator. And the odds, it's occurrence to non-occurrence. So non-occurrence is the number of stage 2s or 3. The denominator of the odds ratio is the odds of being stage 1 in 2019, where the denominator is going to be, again, non-occurrence, stage 2 to stage 4 in 2019. Now, this number is guaranteed to fall with less stage 1 in 2020, right? I mean, it's coming out of the numerator. This is guaranteed to fall, even if there's no change in late stage disease. Now, the second one is the odds of being diagnosed with stage 4 disease. So they're sort of flipping it around, and now occurrence is stage 4, and non-occurrence is stage 1 through 3. So it looks something like this. Stage 4, 2020 over non-occurrence stage 1 through 3, 2020 over stage 4, 2019 over stage 1 to 3 in 2019. Now, of course, this is guaranteed to rise with less stage 1 in 2020, because look where stage 1 is now. It's in the denominator of the numerator. All right, and this, even with no change, it was guaranteed. It was guaranteed to happen, even if nothing changed to stage with late stage disease. That if just a simple change in stage 1 was going to increase the odds of being diagnosed with late stage disease, and it was going to decrease the odds of being. And so it's like, wow, this is just so bad. And if you find this all hopelessly complicated, it's another reason to avoid odd ratios, right? This is crazy. You had a hard time reading it. I have a hard time figuring it out. It took me a while to, even though they said right in the sentence, I'll give them credit. They were pretty clear, they were clear the last few words, I'm sorry, I can't point to, stage 4 versus stage 1 to 3. At least they were clear about what occurrence and non-occurrence was. So I'll give them credit for that. But it's awful, right? When the real information you wanted to know was simply what the absolute rate of stage 4 disease was. That's all you really want to know. And in fact, it hadn't changed much. Okay, as you can see, I get pretty excited about it. Any questions on that? Or different interpretations? Yeah. Yeah. Yes, you would. It's the ratios. It's the ratios, yeah. And the odds just make it a little one step a little harder for most people to even digest what's happening. They just and I'm curious, what were they adjusting for? Were they adjusting for temperature in the year? What changed across the 2 years? I don't know. Adjusting. What are they adjusting for? The amount of precipitation in 2020? I don't. Okay. Survival. Survival is typically, first it can be a 5, 10, 13-year survival, but typically one of the most common measures is 5-year survival. So the numerator is the number 5 years following diagnosis. The denominator is the number of cancers diagnosed. And we got the same problem with that denominator may change, right? That denominator may change, and the time people get there may change. Now, there are 2 major biases associated with this measure. Some would say 3, but I try to always simplify things for medical students. And by the way, how many of you do teach medical students? Okay, I want to be clear that please share these slides. If you think anything's useful, please use it, because my goal is to get medical students to understand these topics. So first, we have to be clear what survival time means. And this arrow is meant to represent a survival time. This is the point of diagnosis, and this is the point of time of death. So it's a measure of survival time. So this would be true for measures of median survival or proportion living, 5, 10, 7.5 years. That's what survival time is. Now, what does longer survival mean? Now, I've been doing this for 30 years, and it's still hard for me not to hear longer survival, not to hear it and interpret it as being on this end of the arrow. We assume it means a delayed death. It just sounds that way, right? Higher survival, longer survival must be on that side. But of course, it may simply mean earlier diagnosis. It may simply all be happening on the other end of the arrow, the time of diagnosis. You're simply advancing the time of diagnosis. I'm going to show you that once more because I think it's sort of a powerful image. I found it to be a powerful image with medical students. If you do, I want you to use this because I think it really helps describe the so-called lead time bias. We hear longer survival, we assume that it means delayed death. It just feels that way, but in fact, it may, oh, now I'm going the wrong way on this, may mean earlier diagnosis. So I think it helps to start with a very simple example. I'm going to give you 10 patients with clinically diagnosed cancer. This patient is diagnosed and dies 8 years later. This patient is diagnosed and dies 2.5 years later. This patient is diagnosed and dies 4 years later. This is 1 year later, so on and so forth. Now I have 10 arrows or 10 patients. At this point, you should be thanking me for a convenient denominator, right? What is the 5-year survival? Let's pretend we weren't in the room of epidemiologists. What would you say the 5-year survival? It's a proportion. What proportion for? 30%. Right? It's not hard. You see that. You just say which arrows are longer than 5 years, and you say 5-year survival equals 3/10. 30%. Easy, simple. But now, and this is about the belief of the lead time associated with mammography. Of course, it's very variable and so forth. But that's a kind of range. 2 years of lead time is what we might expect from looking for small forms of cancer. So we find this cancer 2 years earlier. That patient lives 10 years, even if there's no change in the time of death. And this becomes 4.5. This becomes 6. This becomes 3, and so on and so forth. We're adding 2 years at one end. What the animations work, and what's the 5-year survival now? I need a number. Everybody convinced of that? Yeah, the biostatisticians backed you up there. That's good. That's good. You're good. And so your 5-year survival is 7/10 or 70%. Now you understand how lead time can really inflate survival, right? Varied lengths, different speeds of growth, but it definitely moves it only in one direction. That's the bias. It systematically moves it in one direction. Very tempting to think that something good has happened. But in fact, I'd argue something bad has happened. We've told a bunch of people 2 years earlier that they have cancer. And I see that as a harm. That in itself is a harm. Even if we didn't treat it, that's a harm. Now that's one bias. Yes.
But just to be devil's advocate, if some of these patients really did benefit from early detection,
Oh, absolutely.
didn't, just from this alone, you can't say.
I can't tell you that I cannot tell you that screening didn't help any. All I can say is that if it didn't help anyone, it will still look great. That's the point. You can't make any assessment about its effectiveness through this measure because this measure will always go up. We call it a lead time bias as if lead time's a bad thing. No, that's exactly what screening is trying to do. It's trying to introduce a lead time. But just by that fact, you cannot measure survival time as the outcome to judge the efficacy of the effort. It will always go up. Does that help? Yeah. Okay. So overdiagnosis bias, that's less familiar. Most medical students kind of know lead time bias. Overdiagnosis bias is a little harder for them. But imagine that before screening, among 1,000 patients diagnosed, that 200 were alive 5 years later. Well, that's easy. How many people died here? 800, and the 5-year survival would be 20%, right? Easy numbers. So we got 5 years survival. That's good, but it's good to do the numbers, and it's good to have students do the numbers. It's good, so this isn't complicated. This isn't the odds ratio. This doesn't take some knowledge of exponential functions. This is, math they would have learned in 6th grade. But they should be sensitive to it. So now, imagine after screening that you now diagnose 400 patients with a disease that was never destined to kill them. 400 overdiagnosed patients. Now, I won't make the case that this exists right now. I guess I'll come back to it in a second, but I think it's now broadly accepted that some degree of overdiagnosis happens with any screening test. So now the denominator has been inflated, right? So we've got 1,400 diagnosed. But also the numerator's been inflated because those 400 are bound to be alive 4 years later. So that's 600 diagnosed. And this may be less intuitive, but if you inflate both numerators and denominators, proportions rise. And in this case, I won't make you do the math. It's 43%, but notice there's still 800 deaths. And that's important to point out. Do the subtraction. You've still got the same number of deaths. Now, all I'm saying is here again, I'm making it simple with the screening has no benefit. Under the condition that screening has no benefit, it will still look like it's great. Even if screening has benefit, the benefit will be exaggerated by this because it's a biased measure. Any questions on that? Yeah. Yeah, of course you can. No. Yeah. Oh, we're going to get to that. Yeah. We didn't. Yeah. Let's see. But the only thing to understand is measuring survival time will always go up with screening, even if it has no effect. It will always go up. So I just want to show you how screening was promoted, lung cancer screening in Taiwan in the last 20 years. These are sort of the advertisements that were out there. I know most of you aren't clinicians, but I'm curious if anything about the pictures bother you in the context of lung cancer screening. Pretty young people. What would you say? Would you make any comment about their sex or gender? Sex, I guess.
I don't have a glasses on, but I'm pretty sure female.
Yeah, they kind of look female. I'll tell you, women do not smoke in Taiwan. I mean, 95% are non-smokers. Men smoke because we were there in World War II. We had a lot of cigarettes around, and so we got them smoking. But the women never really smoked. And that's since 1980s. They're less than 5% smokers. And these are young women. And in fact, I particularly like this, and I was working with a Taiwanese epidemiologist, and he translated some of these for me. And one of the lines was, women are genetically more fragile and cannot easily repair disease cells, and they should be regularly checked. Yeah, so if you're a woman, you should really worry. Don't ignore the fact your life expectancy is longer than men and all that. Because this sounds like science, genetically more fragile. Oh yeah, yeah, I don't know. How do you do it? That's my question. So did they find more early stage disease? Absolutely. They found remarkable amounts of early stage disease. Stage 0 to stage 1 lung cancer went up 6-fold, but you'll notice late stage incidence didn't change at all. But you've still got this very favorable change in the stage distribution. You're going from 90% late stage to now 60% late stage. That sounds really good if you don't look at the population data, right? And so again, showing you how misleading stage distribution is. And then Of course, I don't want you to. I want you to look at just stage-specific incidents, and you can see what's happening. You're identifying a new category of disease that was previously unidentified. They're largely small peripheral adenocarcinomas of the lung. Yes, there can be overdiagnosis in lung cancer, the most feared cancer there is, because there's a lot of heterogeneity in cancer. And then you obtain the highest 5-year survival for lung cancer in the world. And this shows Taiwan breaking out of the pack for 5-year survival among women with lung cancer from all these other OECD countries. And you can see they're now at 40%, which and you can see how misleading that feedback is. And everyone assumes it's a good thing, and it leads to more screening, and it leads to more overdiagnosis, and it leads to more pulmonary resection. And you don't have to be a physician to know it's not good to have part of your lung taken out unnecessarily. So it's not like it's a trivial problem. And lung cancer mortality is unchanged, yes.
Okay, well, that was my question.
Yeah.
Clinically, not knowing a ton about lung cancer, compared to, but are there data to suggest that there are somewhat benign or less?
Absolutely, absolutely.
That would not ever.
We've been worried about it since the Mayo Clinic trials in the 1980s of chest X-ray screening. Yes, there are data, and there's autopsy data, and there's just a lot of difference between lung cancers. They're aggressive, smoking-induced squamous cell lung cancer. But if we look at everybody with spiral CTs, we will find, and the Japanese did this, find almost as much lung cancer in smokers as non-smokers, in non-smokers as smokers, which is like crazy, because you all know Dahl Hill. You know the relative risk of dying from lung cancer is around 20 or 30 for smokers. It's likely the most powerful exposure, but it's something different. Dying from lung cancer is something different than having an abnormality found on cross-sectional imaging. Very different concept. Whoa.
So, but couldn't I mean, now we talk.
Yeah.
You know, when a large percentage of the population smoked, we did the studies, by definition, that would dwarf almost the attributable risk from other non-smoking factors. But as smoking rates have dropped precipitously, I'm sure you saw where there was publication last month about rising rates of lung cancer.
This is so great, but it's not rising rate, it's rising proportions of lung cancer in non-smokers. In hospital-based studies, increasing proportion of lung cancers being treated are occurring in non-smokers. That sounds like, oh my God, there's more lung cancer out there. But no, what it is there's less smoking and less smoking related cases. So yeah, I know exactly. And that was another awful.
Do we know though that the clinical course of non-smoking related lung cancers is more benign?
Yes.
Than smoking related?
Absolutely. Excuse me. What we know is that the course of screen detected small peripheral lesions is much more benign, and they're typically adenocarcinoma. So I'm hiding a little bit of the cell type issue, which is a huge determinant. Right. But there are a lot of innocuous small lung cancers, and that's the downside of spiral CT screening, and that's one of the reasons that part of the effort to screen carefully began to require following small abnormalities over time to see if they in fact grew, which is like a total, imagine having a mammogram, being told you have a lesion, but being told the right thing to do. And in fact, the right thing to do was to check again in 6 months instead of immediate biopsy.
Well, wait. So bringing this back to the United States.
Yeah.
We have at least 3 large screening programs endorsed by guidelines from August societies in the United States.
August. Okay. Yeah.
CT for lung cancer, colonoscopy for adenocarcinoma of colon, and as you referred, mammograms.
Right.
For, breast cancer. So the question is, has anybody looked at national mortality rates in the United States and seen any sort of secular trend related to screening programs?
Not to screening. First, lung cancer screening, thankfully, has been very slow to take off. The recommendation and the august support is for smokers, heavy smokers, not non-smokers. So no one is suggesting a population-based lung cancer screening.
But if these programs are successful, I mean, with the attributable risk of smoking in lung cancer mortality, one would expect, perhaps not in 5 years or in 10 years, but in 20 years, it's the lung cancer mortality with an unconditional denominator decline, and breast cancer mortality with unconditional denominator decline, and colon cancer. And I guess that would be the real test.
Well, no, that conflates a lot of things that may be leading to declining mortality. All three of those cancers have declining mortality. All three. Lung cancer, largely driven by less smoking. And that's been going on for now 20, 30 years. Colon cancer has been going down since my father died of the disease in 1980. And so it's been going down 40 years, long before we started screening for it. And breast cancer mortality, we're going to talk about in a second, and it's been falling since about 1990. But whether that has anything to do with screening, well, that's a different question. But by the way, I just want to be clear that the example of overdiagnosis bias I gave you is really driven by Taiwan. That's about what was observed in Taiwan, moving from about 20% to 43%. That's about what was observed in. So I think those survival statistics are primarily driven not by lead time, but by overdiagnosis. I'm going the wrong way here. So the unbiased measure is mortality, which is, of course, the number of cancer deaths over the population. And now we'll come back to the whole question of what lowers mortality, because other things besides screening, it's not just screen, it's not like screening is the only thing that can, we tend to default to assume that early detection is the source of lower mortality rates. Do you guys know what that is? I know you're not political scientists, but this is another august body, right? Yeah, so I want to tell you about some legislation that's in front of the House right now. This is House Bill. It's been revised for 2023. You have to reintroduce a bill every session. And this is the Medicare Multi-Cancer Early Detection Screening Coverage Act. And I'll just show you one part of the bill because I think it's a powerful example of how these statistics are misused. Detecting cancer early before it is spread throughout the body saves lives. Cancers detected when still localized can be treated more effectively and have a 5-year cancer-specific survival of approximately 90% compared to approximately 20% for cancers found after metastasis have occurred. Now, this is going to address your stage question, right? Because this is the kind of language that is always used to promote early detection. And I want to be clear that these are roughly right. 5-year survival for patients with localized cancer in the United States is about 90%. And 5-year survival with patients presenting with metastatic cancer is about 20%. So these numbers are right. But why is this not evidence for this? That detecting cancer early before it is spread throughout the body saves lives. Now that's a hard question, right? That is a very hard question. I think a lot of you say, well, yeah, probably, I don't know, what would you say? There's a number of things at play here. John, what would you say? So medical students trying to understand this, right? A medical student, look, these are the numbers they're thrown around all the time. I see them in different forms and different guises. I see stage-specific survival data. And why isn't that evidence that early detection saves lives?
there may be, more important differences between those two groups of patients, like for instance, if people with metastatic cancer are 80 years old and people with localized cancer tend to be 40.
Okay, so just to be clear, this would be so-called relative survival. So it would compare 80-year-olds to 80-year-olds. But that's a reasonable, yeah, this is, so all our survival statistics are relative to the general population of the same age structure, just to deal with that problem. Any other, you want to chime in? What?
Cancer, I guess, you'll probably say, no, there's an example of that generally progresses through time in its stages. So this isn't evidence that a patient identified with stage localized cancer who is never told, and we see the counterfactual, what would have happened to them absent intervention.
Okay.
Because by definition, potentially they would have that same survival even.
So I think what you're now referring to is you would, if you had to call that a name.
Early detection bias.
Well, I think that's lead time. I think you're talking about, I think what I hear you saying there is lead time bias. And that's certainly one of the explanations. I think the first one that mostly might not occur to you is we may not be able to find some metastatic cancers early. And I know that sounds like, oh, of course we can. But ironically, it's the worst cancers that present as metastatic. The most aggressive cancers, the so-called birds, the cancers that may already be systemic at the time of diagnosis. And this was really first recognized in breast cancer. It was Bernie Fisher that really made this comment. For some women, it's a systemic disease at the outset, and so the first hidden assumption behind these, that those two statistics mean early detection saves lives. The first assumption is you think you can find metastatic disease earlier, and that may not always be true, particularly for the worst cancers, the absolute worst cancer. And they're of course the largest contributor to mortality. The second is what you were suggesting. We may be able to find other cancers destined to become metastatic earlier, but not change the time of death. That's really speaks to the lead time problem. But the third deals with this localized thing. The high survival statistics associated with early stage cancers doesn't simply reflect lives saved. It also reflects people told they had cancer that was never destined to bother them, never destined to cause symptoms. That 90%, that's driven by breast cancer and melanoma. They have those early stage survival statistics for breast cancer. If you looked at just DCIS, the relative survival is over 100%. How is that possible? You know how that's possible? Relative to the same age structure of the general population, DCIS is over 100%. So is melanoma and situ.
Because the population that have a diagnosis are healthier than average.
Wealthier, healthier, all that. Yeah. So we assume that early stage number reflects life saved, and that's just so great until you understand that it's driven in part by overdiagnosis, particularly in breast and melanoma. Using survival statistics to argue for screening always leads to the same answer: more screening. I mean, it's not complicated. You don't even need if you're going to use survival statistics to argue for screening, you screen for everything. You'd always screen. Now, I really wouldn't expect Congress to understand that, but I sure as hell would expect their aides in healthcare to understand that. It's really very misleading. When someone juxtaposes the words survival and screening, alarms should go off. Either they don't know what they're talking about, or worse, they are deliberately trying to mislead you. They know it's just a convenient way. It's an easy sell. What do you call it? Compelling narrative. And it is a compelling narrative, but we need to inoculate people against it. It's just totally deceptive. Here's Grail. This is Grail promoting the so-called Galleri. This is multi-cancer detection screening. This is really looking for cell-free DNA, tumor-associated DNA, bits, fragments of DNA that are associated with tumors. It's a simple blood test, so it's nothing for the patient. About $1,000 a pop. Here they're going 4 times health outcomes. When diagnosed early, the 5-year cancer-related survival is 4 times higher than diagnosed in later stages. In fact, that's roughly correct, but the inference they're encouraging you to draw is totally erroneous. And this, I think, is really interesting. Cost of care. They're playing the cost card because it's going to cost $1,000. In fact, I was talking to some folks at CBO because they say they're arguing this is going to lower cancer costs. I'm just sort of, yeah, right. I mean, because they say early stage cancer is on average 3 times less expensive. Isn't that a weird one? Let's say 1/3 as expensive as late stage cancer in the first year after diagnosis. Well, there's a bunch of it. First, I'm not sure that's actually accurate. It sort of depends on what drugs are being used in that first line treatment. But the more important question is twofold. One, they're assuming there's no extra diagnosis, that there's no additional early stage cases, that you're not going to be treating more cases. And of course, if you're treating more cases, then all of a sudden this argument falls flat on its face. But the other thing it assumes that an early stage cancer will never go on to be a late stage cancer, right? And occasionally, an early stage cancer is very much destined to become, despite treatment, a late stage cancer. So this is an assertion that I think is incredibly optimistic. Both assumes that the test will have no effect on the number of early stage cancer treated, and that all those early stage cancers will never become late stage cancers, and thus you'll save that money. So again, these are both biased measures. The unbiased measures are the so-called population-based measures. I call them case-based versus population. The case-based measures are among those diagnosed, and that is something that the healthcare system influences. It's very easy for us to influence the number of cases because we can change the number of early stage cases. By looking harder, we'll always find more early stage diagnosis. The population-based measures obviously use the population as a denominator, and that's a relatively stable number that's unaffected by medical care practice. August bodies support this. I definitely know that. I'm going to assert this, and I know this is countercultural, and you think, oh, I don't care about women or whatever. Not true. The benefit of screening mammography is far more uncertain than widely appreciated. I want to just show you the stage-specific incidence again. I started with that. This is early stage incidence rising after the initiation of widespread screening mammography, and this is late stage incidence. And one of the things I think is important to interpret this curve is to understand what an effective screening program should do to stage-specific incidence. If early stage starts here and late stage starts here, as it does in breast cancer, and you initiate screening, you expect to find more early stage disease, of course, but at the same time, you expect to see a decrement in late stage disease. In other words, the whole goal of screening is to take a woman who is destined to be on this curve and put her on that curve, advance her in the time of diagnosis, such that you don't change the overall incidence much. Now, I'd say this imbalance suggests 2 things. First, screening mammography largely fails the first prerequisite for a successful screening program. It does not lead, or appreciably lead, to fewer women presenting with late stage disease. It has a little bit of effect, but not much. It did change that number. And screening mammography is associated with a substantial amount of overdiagnosis. All this excess with a relatively small deficit. Again, the ideal screening program wouldn't change the amount of cancer very much. It would simply take people who are going to be late stage, destined to present at late stage, and turn them into patients found at an early stage. Now, I'll admit, that's kind of complicated. That's kind of hard for students to understand. It's a hard argument to make, like you have to think about it. So let me give you two more simple pieces of evidence and just see what you think of it. I want to start with the good news and come back to your question of mortality, a good measure, population-based rate of breast cancer. This is breast cancer mortality in the United States. And it's pretty was stable till 1990, and then it's fallen precipitously. It's down by about 40%, over 40% now. That is unambiguous good news. We should celebrate it. It's one of the real advances in medicine. And it's really tempting to ascribe it to screening. But we know in the field, we know that treatment has changed dramatically. And this is the early breast cancer trialist group. This is a group that has been sort of following breast cancer therapies. And when they did the review of the advances in chemotherapy and hormonal therapy for early breast cancer, found for women with ER positive cancer, that's the subtype that's most common. It's 80% of breast cancer. The RCT suggests that the advent of adjuvant and hormonal therapy developed in the late 1980s, early 1990s, have resulted in a 50% decline in mortality. So there's no question that this could be about treatment, right? So that's the first thing. Sometimes treatment gets better. And I'd argue here treatment has gotten better. But this is a pretty simple observation. This decline is observed both in women of screening age 40 plus, but it's also observed in younger women who are rarely exposed to screening, those less than 40. So among women less than 40, and breast cancer is rare, but it's not like it doesn't occur, it's actually declined faster than it has in women over 40. That's a pretty powerful argument that screening isn't a big part of the story at the very end. The big part of the story, you know, both the exposed and unexposed to screening groups have both experienced a similar decline. The good news is largely about improved treatment, not screening. Now, I'll show you one more and then I'll be done and just give you another sense of this. I'm now going to separate this out into the women 50 plus. And this is their mortality since 1960, and it rises a little bit in between 1960 and 1980, stable for the 90, and then you see the decline. By the way, it looks almost the same pattern as is seen in the UK, although it's at a higher rate in each case. Now, the reason I focus on women over 50 is because this is what both countries did when they initiated their screening. They screened women over 50. Screening became common in the United States, as I said, during the decade of the 80s. The National Health Service in Britain initiated a system-wide program for women over 50 in 1989. In both groups, the population age 50 to 70, in both countries, the population age 50 to 70, about 70% are screened regularly. Now, this is women age 40 to 49. Now there's a big difference between the US and the UK. The UK does not screen these people, these women of this age. They do not screen women of this age. While we have, and we have relatively aggressively, an amount more around 60%, pretty stable over the years. And yet you see the same pattern. In fact, again, if anything in the UK, the mortality rate drop is even more dramatic. I think this is another powerful argument. This has got to be largely about treatment. I'll throw in one more country, Switzerland, which rarely does mammography screening at all. Most cantons don't even have a screening program. Cantons are their counties or states or something like that. Less than 20% of the population age 40 plus have been screened. In fact, the Swiss Medical Board recommended against screening mammography, one of the few august bodies to do so, but they thought the evidence base was weak and the harms were very real. And yet Switzerland is experiencing exactly the same decline. And my basic point is, of course, treatment matters, and consider, I think everyone wants to default when there's good news, it must be about early detection, part because of these bias measures thrown out there. It seems so intuitive, but in fact, what really matters is treatment, and we've gotten better at it. Good news is largely about improved treatment, not screening. I'll stop there. Bias measures. The widespread assumption about the benefit of cancer screening in general stems from these bias measures. That's an assertion. Thank you for your attention. I know we want to eat lunch.
So just a few minutes, I'm going to tell you about the Innovator in Diagnosis Award that we'll be giving Dr. Welch in a few minutes. This is the first year, and we'll be giving it annually to somebody who has significantly changed our understanding of diagnosis in clinical medicine in a way that improves patient care. So the Center for Innovation in Diagnosis started in 2021, and we mostly have been trying to work on teaching materials that are on testingwisely.com, like a flipped classroom and open access videos, and a game to practice diagnosis and disease calculators. And current work is leading a task force on diagnostic stewardship with some professional societies, which is trying to change the way that diagnostics are used by implementing them differently in the health system. And then also leading CDC efforts on a core elements of diagnostic excellence to try to promote individual hospital diagnostic programs. So, and that's a picture of the website. So, and let me tell you a little bit more about Dr. Welch now after he's presented his talk. So I've always found his arguments to be clear and compelling and interesting. But he's also, achieved many sort of, very objective measures of success. He's had many New England Journal pieces, as well as JAMA, BMJ Annals, and many others. Written many op-eds in newspapers, which I think is great to try to translate messages to the general public, as well as written 3 books for the general public, which I think really advanced, especially overdiagnosis, just ways of thinking about the process more broadly. And I'd argue that he saw a pattern clinically as a physician, and researched the epidemiology and was able to describe it to the public and policymakers. Although, he highlighted that Congress it's doing the opposite. Yeah. People have heard of it, and it's progress, I think, like moving the dial somewhat. And I think he's changed how we think of diagnosis and evaluate the impact of test-based interventions like screening. And so for that, Dr. Welch is being presented with 2023 Innovator in Diagnosis Award.